So, good evening, everybody. I'm Henrik Teuber. It's my pleasure to present the first case report in our Ballgrist USZ case report series. My case is about a 72-year-old female with persisting right groin and back pain. She presented to our clinic for the first time in January 2018 with persisting groin pain for 6 months and lower back pain for about 3 to 4 months. Her pain radiates into the right thigh and is weight-bearing dependent. She has no pain when she's lying down. She has a history of a fall from standing height in July and October of 2017. And then in November of 2017, she was diagnosed with spinal stenosis with a right-sided L4 radiculopathy. And she received a bilateral microsurgical decompression of L3, L4, also in November. Just a bit for relevant past medical history. She has relatively pronounced degenerative joint disease. She had bilateral hip replacements, the left one in 2008 and the right side in 2010. And then she also had a right hip replacement in 2015. And she has severe osteoarthritis of the lower lumbar spine. On top of that, she has therapeutically well-managed osteoporosis that was diagnosed several years earlier. Back to the present case or history of present illness. After the decompression, she still had persisting pain in the groin and in the back. She was still taking pretty high doses of oral opiates and had decreased activities of daily living. So a conventional x-ray of the pelvis was ordered in December of 2017. Kind of sort of the first thing that maybe jumps out a little bit is the iliopectoral line has a little bit of incongruency here at the level of the acetabulum. So if we take a look at that a bit closer and we look at the lateral, we see the incongruency again. Does somebody see something in the lateral x-ray? There's kind of this hypodense line up here in the posterior column that looks a bit worrisome for a fracture. And then we also see some osteolysis near the cup of the hip replacement. So after this x-ray, the patient was consulted to a hip revision specialist, and he started off with ordering some additional imaging. Any ideas on what imaging studies would be useful? Let's take a closer look. So the first thing that was ordered was a CT. That was in January of 2018. And then we see this pretty old-looking fracture of the posterior column, and then also a fracture of the anterior column with some osteolysis medially. And then the axial view, here's a nice view of the posterior column fracture. This is what it looks like in the 3D reconstructions. Also see the anterior column fracture is well seen. That's here and here. I don't have an image of the posterior column. And then we kind of also have a hint at the osteolysis and defect of the acetabular roof over here. Then looking further, we also see this. So we see a bilateral sacral olive fracture. It looks like it's relatively old. Looks like the bone is trying to remodel. And I don't have a good image of it here, but in the sagittal plane, we can also see a transverse fracture of the sacrum at the level of S1. So this has a specific name. It's called an H-type sacral fracture. Additionally, there was also a fracture of the inferior pubic ramus, but that was well healing at the time of initial presentation, and she was asymptomatic. So we just let that be. Before we dealt with our problems, we decided it would be a good idea to get an MRI of the lumbar spine to sort of see what level of spinal stenosis there was or wasn't. This is an axial view of L3, L4. We see the status post surgical decompression, but we didn't really see any significant spinal stenosis, and there were no signs of neuroforaminal stenosis either in the MRI. We do see the sacral fracture quite nicely, though, in the MRI. So that's everything from an imaging perspective. Does anybody want to summarize the problems we have? We kind of, starting with the hip, we have a right both column periprosthetic acetabulum non-union. We assume that this fracture, or she fractured her acetabulum back in July when she had her initial fall. And then in addition to that, we see a certain degree of cup loosening with a certain defect of the acetabular roof. And then together with the sacrum, we have a symptomatic spino-pelvic instability with an osteoporotic sacral H-type insufficiency fracture. So we've got a couple of construction areas, if you will. And then the question is, how do we treat this patient? So we decided on a three-pronged approach that we would do with two surgeries. First, we dealt with the sacrum, where a mini open llio-lumbar fixation from L3-4 to the ilium was done with an additional left-sided S1 transsacral screw fixation. And then we flipped the patient around, redraped, and did an ORIF of the anterior column of the right acetabulum. And there we used a modified Stapa approach with a preformed suprapectinal plate. And on the plus side, the anterior column fracture was quite displaced, and the defect in the acetabular roof was also pretty pronounced, that we were able to take tissue cultures and histopathology of the hip, and we didn't have to do a separate hip puncture. That was it for the first surgery. We let her recover for a few days and waited for histology. And then the second phase was minimally invasive acetabulum revision, where we chose to do a bulk allograft reconstruction of the acetabular roof and then implanted a press-fit acetabular reinforcement ring with screw fixation and a cemented polyethylene cup. Those are the post-op images of the first surgery. You see the iliolumbar fixation on both sides here, from L3 to 4 into the ilium, and then also the transsacral fixation at the level of S1, and then here the reduction and fixation of the acetabulum with the pectinal plate. Then 4 days later, we did the hip revision, and that's what that looked like. And that was it. The patient did quite well. We didn't have any post-operative problems. She stayed in the hospital about a week and then went straight into rehab. And then we saw her for a 6-week follow-up. She had no limp. She was full weight bearing without crutches. She had almost no pain. She did have a slight residual pain in the right groin, but almost nothing. And she was very, very happy about it. We took a couple of scores as well. They showed high patient satisfaction and also hip function. The EQ5D, she scored the well-being as 100%, and the moral hip score had 17 out of 18 possible points. And her timed up and go was pretty good also at 9 seconds. Then we had some post-op x-rays. We didn't see any loosening. We didn't see any secondary displacement of the fractures. And that's our current stand. Here's some inlet and outlet views also of the pelvis. And then this was her gait at 6 weeks post-operative. A couple of quick words to llio-lumbar fixation. I'm not going to talk about acetabular revision too much since you guys are the experts at that. Llio-lumbar fixation for spino-pelvic dissociations, which basically means unstable sacral fractures, was first described by the Schiltauer group in 1998 as a triangular osteosynthesis. These are pictures from their original study. It looks quite similar today to our surgery. And since then, there have been multiple clinical and biomechanical studies that have shown excellent clinical results and also excellent stability. The last biomechanical study was from the Giazzini group in 2017, which showed that iliolumbar fixation with transsacral or iliosacral screw fixation was the most stable biomechanical construct in all planes, meaning axial rotation, meaning flexion extension, meaning translational side bending. And that basically allows for early full weight bearing. And then in today's age, there are also multiple minimally invasive percutaneous systems. So it's a quite well-tolerated procedure. Pain can be controlled quite quickly in these, also in osteoporotic patients. Does anybody have any questions at this point? So in summary, differential diagnosis in elderly osteoporotic patients is very important. As you guys all know, groin and back pain are symptoms for a broad range of problems, and pelvic and sacral fractures are often missed. Some studies show up to 75% in neurologically intact patients. I thought that was quite high, but interesting. So to summarize, we recommend that if you're ever uncertain or if there's any uncertainty in the diagnosis, to always order a CT of the pelvis. Make sure we can rule out any insufficiency fractures. Then also this case kind of highlights nicely the importance of customized treatment plans in combined lumbar pelvic injuries. Also combining certain surgeries together with just flipping the patient over. And then finally, as a good take-home message, iliolumbar fixation with iliosacral screw fixation is a very stable construct and can be used for unstable sacral fractures. And that's it for the first case. Anybody, any questions?
You combine the first surgery with the iliolumbar fixation together with a stop approach for the
Yes.
anterior column. I just think, wouldn't it be possible to do it all together in a one-stage approach, and instead of a stopper, you turn it to a lateral position and just reconstruct the posterior column with a Burgschneider cage and implant? Because I don't think that it's really necessary to reconstruct the anterior column. So that's my question. Did you discuss the one-stage and two-stage approach?
Yeah, that's a very good question. That absolutely would have been a justifiable approach, but we didn't know if she may have possibly had an infection in the hip, and so we were thinking we could gain histopathology and rule out a low-grade infection to help us for the revision of the acetabulum. That was our sort of thinking.
So you did go to L3, is that right?
Yep. We went to L3 because she has a high degree of osteochondrosis of the pelvic spine, and we wanted as much stability there.
Okay, and she had pain before this accident, or lumbar pain, I mean?
She had lumbar pain for about 3 to 4 months when we met her. There's it's a good question. There was one CT scan done in October where the posterior column fracture was already visible. There wasn't a complete cut of the hip. I can take a look at that. And we can also see, it's not well seen, but back in October she probably already had the beginning of the sacral insufficiency fracture. And she did have that fall in October.
And the last question, you used a fenestrated screw. Is that I can't see it really.
Yeah.
But you didn't use cement.
We did not use cement, no. Any other questions? Then thank you guys very much for your time. That's it from my end.